Good morning, everyone. At the outset, would like to thank Shona ma'am and Sudeep sir for giving me this opportunity. So I'll be presenting three abstracts. My first abstract is basically a long-term outcome of adjuvant denosumab in breast cancer. This is basically a fracture reduction and survival results from 3,425 patients in the randomized double-blind placebo-controlled ABCSG-18 trial. So this is a trial design of ABCSG-18 where it is a prospective randomized placebo-controlled double-blind multicenter phase 3 trial where patients will be randomized into arm 1 with denosumab 60 mg subcutaneous every 6 monthly, whereas arm 2 is placebo subcutaneous injection every 6 monthly. So the primary endpoint of this trial is time to first clinical feature, and a total of 3,425 postmenopausal patients were recruited from 2006 to 2013. So, as I have told, the primary endpoint is time to first clinical feature, whereas the secondary endpoints are percent change in bone marrow mineral density and vertebral fractures, whereas the secondary outcome related secondary endpoints are disease-free survival, bone metastasis-free survival, and overall survival. So, a total of 3,400 patients were there. Out of which 1,711 patients were randomized to denosumab arm, whereas 1,709 patients were randomized to placebo arm. A total of 554, that is 16% of patients chose to be unblinded, and at a median follow-up of 8 years, the total of DFS events were 20%, whereas 8.3 were the deaths. So this is the primary endpoint results. You can see out of the 1,711 patients in denosumab arm, only 92 patients have fractures, whereas in the placebo arm, out of 1,709, 176 patients has fractures. So with a hazard ratio of 0.50. So these are the clinical characteristics, and if you see the secondary endpoint, again, if we see the disease-free survival, there is absolute benefit of 5.4% in those patients who received denosumab as compared to those who are on placebo arm. If we see the bone metastasis-free survival, again there is 4.4% absolute benefit in those patients who received denosumab as compared to those who are on placebo. And if we see the overall survival, again a secondary endpoint, then there is definite 5.2% improvement in overall survival in those patients who are on denosumab arm as compared to those on placebo. So the authors concluded that adjuvant denosumab 60 mg every 6 months during AI therapy is safe and markedly reduced treatment-induced clinical fractures even in long term. The disease-free survival, bone metastasis-free survival, and overall survival are improved in this descriptive final long-term analysis of ABCSG-18, and adjuvant denosumab should be considered for routine clinical use in postmenopausal patients with hormone receptor-positive breast cancer on AI treatment. So, to discuss this is basically distant cells from breast cancer of osteoporotic nature, we all know, and bone is the most frequent site of distant relapse, almost 40% of all distant recurrence, and almost 80% of the patient with metastatic breast cancer will develop bone mets during their disease course. And denosumab is a fully human monoclonal antibody that binds to and inhibits the receptor activity of RANKL1, and it inhibits osteoclast activity that resulted in reduced bone resorption, tumor-induced bone destruction, and SREs. So factors to consider for duration of anti-osteoporosis therapy includes bone mineral density, response to therapy, and risk factors for continued bone loss or fracture, and we need to evaluate them frequently. And also patients who are treated with either bisphosphonates or denosumab should undergo dental examination with preventive dentistry prior to the initiation of therapy and should take supplemental calcium and vitamin D. So take home message from this trial is adjuvant denosumab is an alternative for postmenopausal women with early stage ER positive breast cancer on aromatase inhibitor. You can see there is absolute benefit of at 11 years PFS by 4.5%, bone metastasis survival by 4.4%, and overall survival by 5.2%. My next study is final result from phase 3 randomized clinical trial of adjuvant endocrine therapy with or without chemotherapy in women who are more than 70 years old with ER positive HER2 negative breast cancer and high genomic grade index. That is the Unicenter Aster 70 trial. Now we all know this constant underrepresentation of older patient randomized clinical trials. You can see in the MINDAC trial, the age limit was less than equal to 70 and only 0.8% of patients were there. In TAILORx, again, age limit was less than equal to 75 and only 7% of the patients are 70 plus, whereas 4% are 70 plus with recurrence score of 11 to 25. And in RX Ponder, again, only 12% of the patients belong to the age group 70 to 75 with recurrence score less than 25. So what is the genomic grade index? It is a 97 gene expression signature developed to better define histological grade. It divides breast cancer into low and high risk. So the patients who are included in lower genomic grade index low are those with luminal A, whereas for the genomic grade index high are luminal B, HER2 and basal like. Genomic grade index high is associated with higher PAT-CR rate to neoadjuvant chemotherapy, and genomic grade index risk stratification was comparable to the 70 gene signature and oncotype in previous studies. So this is a typical ASTER 70 study design. ASTER stands for adjuvant systemic treatment for ER positive breast cancer in women over 70 according to the genomic grade index. And you can see they screen a total of 2000 patients, and then according to the fresh frozen plasma embedded RT-PCR, they divide genomic grade index to high or equivalent, wherein a total of 1080 patients are there, samples were there, and in low genomic grade index 900 samples were there. And the primary endpoint of this trial is overall survival if high risk of recurrence according to genomic grade index high or equivalent. So those patients who have high GGI, they are randomized in 1:1 with either endocrine therapy or chemotherapy followed by endocrine therapy. And the chemotherapy, they either give 4 cycles every 3 weekly with GCSF support of AC, MC or TC. So these are the patient characteristics. You can see this in the two arms, they are well balanced. Apart from that, they also stratify according to the G814, which is basically a screening tool for frailty, then Lee score more than 8, which is a 4-year mortality score, and then CCI, which is a Charlson comorbidity index. Now, if you again the tumor characteristics, they are well balanced in the randomized arm, like both the arms with endocrine therapy or chemotherapy followed by endocrine therapy. Now you can see the non-adherence to treatment assigned. So those patients who have been enrolled to chemotherapy with endocrine therapy, almost 20.5% of patients were non-adherent to treatment assigned. And the chemotherapy choice obviously is TC, since age is more than 70 years. And if you see the treatment stopped, almost 6.4% of the patient who are on chemotherapy with endocrine therapy stopped chemotherapy before cycle 4. And again, adverse events are more in patients who are on chemotherapy followed by endocrine therapy. But if you see, even endocrine therapy stopped for toxicity in arm who have been randomized to only endocrine, with 22.6% patient have stopped endocrine therapy due to toxicity. So this is the overall survival that is intent to treat, which is the primary endpoint. Again, chemotherapy with endocrine therapy has little benefit of almost 1.3% as compared to endocrine therapy alone. Whereas if you see the per protocol, again there is a slight improvement in arm with chemotherapy with endocrine therapy as compared to endocrine therapy alone. So if you see the secondary endpoint, that is the breast cancer specific survival, again it is more or less similar, 95.3 versus 97, but invasive disease free survival as per protocol, there is 86.8% as compared to 82.4% in chemotherapy with endocrine. So genomic grade index is prognostic. It does not predict a significant OS benefit from CTET versus ET alone, and there is 20% non-adherence rate to assigned chemotherapy, and the treatment discontinuation again 6% in chemotherapy before cycle 4, and in endocrine therapy it is 22. So my take home message for this trial is all previous trial which assess the clinical benefit of adding chemotherapy to early breast cancer did not specifically address the population above 70 years of age. This trial has shown that using genomic grade index would help patient be stratified as GGI high, which in turn shows benefit of addition of chemotherapy, and decision regarding chemotherapy in elderly patient is complex. Comorbidities and competing mortality risk factors should be considered. My third trial is SOFT trial. Basically, it is the evaluation of breast cancer index in premenopausal women with early stage hormone receptor positive breast cancer in the SOFT trial. So we all know about the SOFT trial, where there are 3 arms, and there's with a median 12-year median follow-up, almost 3% improvement in 12-year freedom from distant recurrence with exemestane plus ovarian function suppression versus tamoxifen alone. So the DRFI benefit for exemestane plus ovarian function was 3% greater than TAM plus OFS. What they said is a breast cancer index, which is a prognostic and predictive. So breast cancer index prognostic incorporates the molecular grade index and Hox B13 IL-17 BR ratio. And breast cancer index node positive further incorporates tumor size and grade for N1 patients, and they report individual risk of late distant recurrence, whereas the breast cancer index predictive model incorporates this Hox B13 IL-17 BR, and it is based exclusively on HIA ratio to assess estrogen signaling pathways. So hypothesis what they want to test in soft population is breast cancer index and breast cancer index node positive prognostic in patient with N0 and N1 disease respectively, and breast cancer HI high status predictive of OFS benefit, whereas breast cancer index HI low status is not, and hypothesis based on previous BCI data in adjuvant therapy. So the primary objective of this trial is if breast cancer index HI predicts benefit from exemestane plus OFS. So this is basically a translational soft translational cohort wherein the final translational cohort is 1687 patients, and these are in this 1687 patient, almost 573 patients are on tamoxifen, 550 on tamoxifen plus ovarian function suppression, 563 were exemestane plus ovarian function suppression. So you can see the breast cancer index is prognostic for distant recurrence premenopausal women with hormone receptor positive, and those patients who have breast cancer index node positive risk group and tumor grade were highly correlated, like those patients who have breast cancer index node positive with low risk have grade 1 tumors, whereas those who have breast cancer index with high risk have a higher grade, like grade 2 and grade 3. So this is again, you can see the predicted result of breast cancer free interval. This absolute benefit of 11.6% in those who are experienced plus ovarian function suppression in those who have BCI H by low, whereas if the BCI H by is high, the benefit is hardly 0.4%. BCI transitional cohort was representative of soft parent trial. BCI risk score was prognostic in premenopausal women with hormone receptor positive tumors receiving adjuvant endocrine, and high risk score associated with worse outcome. And BCI high was predictive of OFS benefit, and contrary to study hypothesis, BCI H by low group considered clinical meaningful benefit while BCI high group did not, and results point to potential difference in the tumor biology underlying the OFS response, and it is the first genomic assay to demonstrate benefit from OFS supporting additional clinical utility of breast cancer in premenopausal women. Thank you.